Hello, welcome to PCR webinars. My name's Rasha Al-Lamee and I'm based at Imperial College in London. We're here today to discuss FFRangio and really discuss whether we're ready for everyday practice. It's my absolute pleasure today to be joined by some very good friends and colleagues, and together we're going to go through where we are today. So we have Bill Fearon here from Stanford, Ajay Kirtane here from New York, both of whom were absolutely instrumental in the formation of the research that surrounds FFRangio, but also importantly in teaching us about the tips and tricks of this technique, as they really have been the pioneers who've really gone forward and taught us about how we use it, taught us about the evidence generation behind it, and obviously are part of leading on the future research that will be done in FFRangio. So today we have a number of very important learning objectives, but we'd like to keep this very interactive. We're going to talk about the latest evidence supporting the use of FFRangio. We're also going to talk about tips and tricks of how to use it in clinical practice and how to make sure you reproducibly are able to use it every day and get the right numbers so that you can guide your practice. And then importantly, we're going to talk about the future and what that might hold for this technology. So importantly, we'd like to keep it interactive. Please ask your questions, and I'll be fielding all of the questions in the chat. We have left lots of time for discussion, but we'll start first with Bill.
Great. Thanks, Rasha, and thanks to PCR for the invitation. It's my pleasure to start by presenting a case that will hopefully demonstrate the day-to-day use of FFR angio. So this is a 43-year-old man, multiple cardiac risk factors, high blood pressure, dyslipidemia, longstanding diabetes, and end-stage kidney disease on dialysis, who is being evaluated for kidney transplantation. He had a normal echo, no significant valve disease, and our transplant team, given his risk factors and longstanding diabetes, requires an invasive angiogram to rule out occult disease. And so this is an areocaudal view of the left coronary, and you see the circumflex has these serial lesions leading into this obtuse marginal branch. Here's a spider view of that as well. And so you see that there are kind of multiple areas of narrowing, and the question is, should we put in one long stent? Should we fix part of it and leave the rest? And if we were going to do this wire-based, it could require multiple steps, measuring either IFR or FFR, and then fixing one lesion after doing a pullback, depending on what that showed, and then remeasuring, deciding if you need to fix the next. But we now have this technique, angiography-derived physiology, whereby we can measure FFR without needing to place a wire or give adenosine based on the angiographic images alone. And I'd like to just go through the steps that we use to do that. So there's kind of four main steps in measuring FFR angio. The first is you need to obtain optimal angiograms. And what we mean by that is just doing a careful job, making sure that you can see the entire coronary tree without significant panning of the table, make sure that you fill the vessel well with contrast, and trying to avoid excessive overlap of branches, and doing some orthogonal views, typical things that we learn during fellowship. Once you've done that, the system will create a three-dimensional reconstruction of the coronary tree. And based on a resistance analysis, it can then provide comprehensive physiologic assessment. And so this is what the console looks like. Basically, as you take your angiograms, they're automatically segregated into quadrants. If it's, areocranial, eleocranial, and so forth, the images show up there. And you choose the vessel that you're going to interrogate. So in this case, we click on left circumflex. You enter the mean arterial pressure. And then once you do that, it will highlight which images are optimal for analysis. And you like to, for the circumflex, you like to have two caudal views and one cranial view. And so you select your images, and then a little plus sign will show up, and you just move that plus sign onto the lesion in each angle, and that sort of acts as a center line. And from that, the system then can create the three-dimensional reconstruction. Once you place it there and then move to the next image, the system will automatically start tracing. So you can see the left-hand panel, the red lines represent the vessel being analyzed, and then there are branches that are already demonstrated as well. And then you're moving on to the next image and putting the plus sign. And so this can happen all very quickly within about a minute. You've identified the lesion, and then you just double check to make sure that the system has traced well. In the vast majority of cases, it does, but rarely, if there's a pacer wire or some overlap of vessels, it may get confused, and you just can correct that. And then basically you click next, and the system analyzes and spits out the FFRangio. And in this case, you see that it was 0.58. And there's a little white triangle that indicates where it's being measured. In this case, it's very distal in that obtuse marginal branch. You can move that back, be proximal to the distal lesion, and place it in between the two lesions. Now you see the triangle has moved, and the FFRangio has changed to 0.73. So roughly about half of the gradient was from the distal one, and the other half were more proximal. Then there is something called the lesion impact factor, where you can virtually stent portions of the lesion, and it'll tell you what the FFRangio would improve to. So in this case, we stent the distal part of the lesion, and the FFRangio would improve to 0.79. If we go ahead and stent the middle part, there's very little improvement. And if we stent both the middle and distal, we get an FFRangio that's up to about 0.90. So it suggests that we should take care of both of those areas. The other aspect that the system allows is called a sizing tool that allows you to measure the length of the lesion to help guide your decision on how long a stent, and also the diameter of the vessel to measure how big a stent you should put in. So in this case, based on that, we went ahead and put in a longer stent covering both of the areas of disease. We checked it with intravascular ultrasound, and we're very happy with the result. We also checked the post-PCI FFRangio, and you see that it was 0.86, so very close to the predicted 0.90. And we were satisfied with this result and concluded our case. So what data do we have to support this approach? This is a study that was called FAST-3, or sorry, FAST-3, FAST-FFR, that both Ajay and I and others participated in, that included 10 centers in the US and Israel, and basically comparing FFRangio to wire-based FFR in about 300 patients. And you see that there's a very good correlation. The overall accuracy was 92% with the wire-based FFR. So this was reassuring, but it would be nice to have outcome data. And this was a study that Guy Whitberg and others published recently. It's an observational study looking at outcomes after using FFRangio to defer or treat vessels. And I think the key highlight is that in the deferral group, you have a very low event rate at 1 year, suggesting that it is safe to base your decisions on FFRangio. There was a randomized trial done in Japan that included 401 patients randomized to either FFRangio-guided therapy or wire-based FFR therapy. And this wasn't designed as a clinical outcome study. The primary endpoint was just looking at the rate of revascularization in the two groups to show that FFRangio was non-inferior and had a similar rate of revascularization. They did look at clinical endpoints as a secondary outcome. And what they found was that there was a very similar rate of revascularization, and it did meet the non-inferiority margin. And so this was a positive study suggesting that FFRangio leads to similar treatment decision compared to wire-based. Now, they also did follow the patients for clinical outcomes out to 1 year. It wasn't powered for this, but the data were reassuring. As you can see here, MACE rate and MACE excluding procedural MI were all identical essentially between the wire-based and the FFRangio system. But of course, it's nice to have large clinical outcome data. And so that was the goal of the All Rise trial. And this is a study that Rasha, Ajay, and I were all very heavily involved in, being on the steering committee together. And it was basically a study including patients in the US, Europe, Japan, Israel, almost 2,000 patients. And the patients were randomized to either an FFRangio guided approach or a wire-based approach. In the FFRangio approach, you would, based on the result of the FFRangio, either perform PCI or defer. And in the wire-based approach, you could do either FFR or a non-hyperemic pressure ratio, and then based on those results, decide what to do. And the primary endpoint was a composite of death, MI, or clinically indicated revascularization at 1 year. It was a non-inferiority design. And there were a number of key secondary endpoints in two, including procedure time and complications, which we'll also discuss. So this slide shows the baseline characteristics. It's kind of a busy slide. The main point is that these were typical patients that we see every day in clinical practice. About 40% were diabetic. A key thing is that only about 10% had acute coronary syndrome. So these were mostly stable patients. As far as procedural characteristics, you see that about half of the target lesions were LAD, and the other half were either in the circumflex or the right coronary artery. The FFRangio value was similar to the wire-based. It was 0.81, whereas for wire-based FFR is 0.84, and for IFR or RFR or whatever, it was 0.89. And so the treated lesions were slightly higher in the FFRangio group, 43% compared to wire-based, 37%. Now, one of the key secondary endpoints is shown here and has to do with the resources used during the procedure. And you see that contrast volume was significantly lower with FFRangio, as was fluoroscopy time or radiation exposure, the procedure duration overall, as well as the time it took to measure the physiology, were all significantly lower within the FFRangio group. So it really streamlined our approach. This slide shows the primary endpoint, the composite of death, MI, or clinically indicated revascularization. And you see that they were essentially identical with overlapping of the curves. The non-inferiority margin was easily met with a highly significant value. When we look at the components of the primary endpoint, they were all similar. Death was similar. Myocardial infarction was similar, and clinically indicated revascularization. So all very reassuring data in this large multi-center study that we can readily apply this technique in these types of patients and have equivalent results to wire-based physiology. So I'll stop there and hand it over or back to you, Rasha.
Thanks very much, Bill. So we've got lots of time today for discussion. I just want to ask you a few questions that have come through already on the chat, and then we'll come to Ajay, and I think we'll keep that conversation going. So obviously, All Rise was a very important landmark study, a study that's really compared FFRangio to all of the wire-based technologies that are out there. The question that's in the chat is, what about a comparison with CT-FFR? What do we know there, and what can we do with that kind of data?
Yeah, so that's a great question. I view CTFFR more as a gatekeeper to the cath lab. And so I think it's most useful to compare that to stress imaging studies and look at the accuracy for identifying significant lesions or patients that need to go to the cath lab. Once we're in cath lab, I think you know clearly if the FFRCT was really abnormal, and then you see a lesion that correlates with that, you probably don't need to redo physiology. But a lot of times the FFRCT isn't as accurate as we'd like, and I think that just speaks to the fact that the CT has lower resolution than angio-derived physiology, and so I think in those cases, it is useful to do additional, physiologic testing with FFR angio to confirm, if you're in the gray zone. I think the gray zone is pretty big with FFR CT, and so I still think there's a role in a fair number of cases. And the other issue is a lot of our patients, 50% or more, are acute coronary syndrome patients where we don't have. Oftentimes, non-invasive imaging or CT, and in those cases, especially in the non-culprit vessels, I think FFR angio can be very applicable.
Great. And sort of in along the same lines, there's now a question about what's the correlation between IVUS-based anatomical assessment. I'm sure you've got a view on this of the minimum lumen area and FFR angio. I mean, I think most of us would say we don't use IVUS for this, but what's your answer to that?
Yeah, I agree. I mean, I think, intravascular imaging and coronary physiology are complementary. I use the physiologic assessment to decide whether or not we need to intervene. And I think it also can be useful for guiding, which lesions need intervention, and also confirming, a good result. But intravascular imaging clearly is key for helping us decide, if you have a calcified lesion, whether you need to do, what sort of pre-treatment you need, and then also after you deployed your stent to make sure that you have an optimal result. So I view them as complementary. There have been some studies with angio-derived physiology comparing to intravascular imaging showing similar outcomes. I think you tend to stent more when you guide your procedure with intravascular imaging. And so I think one of the benefits of using FFR angio and physiology is that you really are more judicious with your stents and eliminate unnecessary stents.
Great. And then maybe one final question for you for now. Someone's asked about the costs. So I know that you're planning obviously a cost effectiveness analysis at the moment. In many geographies, FFR angio is more expensive than the wire, although that's obviously about to change. What your views on the economic piece around using this technology?
Yeah, it's a great question, and we should have more data hopefully soon. As you know, with All Rise, a cost effectiveness analysis is underway, and hopefully in the next 6 months or so, we'll have some further guidance. And it's an interesting question, and a lot of it, will depend on the geography and exactly how the utilization of the system is structured, whether it's a pay for each case you do, or is it a subscription model where you have the system and you can use it as much as you want on as many patients as you want, and you just pay like a monthly fee. All of that, and exactly what the cost is, will probably be the most important factor. I think it's interesting in All Rise, we did have a slightly higher rate of revascularization. And of course, that's going to increase costs, but it's counterbalanced by the procedure being significantly shorter and less contrast use, and maybe some lower complications too. That needs to be further looked into. But so I think it'll be interesting, and I frankly don't know what the answer is going to be. But my guess is that the fact that it really streamlines things is going to win out. That typically is the way things work. If you have two strategies and one is easier and quicker and leads to similar or better outcomes, people are going to choose that.
Yeah, I agree. I mean, time in the lab and the wasted time is often one of the biggest costs in our system, isn't it? Thank you, Bill. Let's move to Ajay for his presentation and we'll come back for more questions. There are lots coming in the chat, so please keep them coming. Ajay, take it away.
Oh, thanks, Rasha, and thanks for having me on. Also, it'll be perfect because I think one of the questions was on CT, and the first case I'll show you involves a case with CT-FFR as well. So I kind of want to mainly show some cases and the way I use this technology in clinical practice informed by the data. And so this was actually a patient that came to see us who had stable angina, exertional angina, and had this CT-FFR. Clearly, the LAD looked ischemic, and it wasn't just a sort of diffuse pattern ischemia that we often see in the LAD distribution. It looked like there were some focal step ups, but I think to Bill's point exactly, most of the time CT is a good way, CT-FFR is a good way of preventing unnecessary patients from coming to the lab. But in somebody like this that has exertional symptoms, yes, you'd want to bring the patient to the lab. And so I view it upfront more as a gatekeeper. The PCI planning portion of it is something that needs to be determined a little bit further. But this is a case where I think the two were very complementary. And so here's the angiogram, and I think you can appreciate in the LAD, there's some proximal disease, there's another lesion a little bit beyond it, and then there's a lesion in the mid to distal segment. And it's very similar to what we thought we would see on the CT. Ordinarily, I think if folks were to interrogate this in a patient that's symptomatic, you might take a pressure wire down and do careful pullbacks. And most people don't remember the formula to sort of figure out the interdependence of the two lesions and that kind of thing. And then other people would say, well, I kind of don't want to go distal, or maybe I should just go proximal and just stent that. But wouldn't you want to do it more precisely? And so that's exactly what we can do with a technology like this. And so I'm sorry, this is a screen capture, so it's real time and imaging. But you can see that the distal value almost exactly mirrors what it was seen on CT-FFR. But on the pullback curve, and Bill showed you this, but I will take you through step by step, you can appreciate there's kind of three different segments of lesions. And what I'm doing here is I'm using the tool to turn lesions on and off to determine what the post physiology would be like. So to do it a little bit more slowly, this is what the pullback curve looks like. And the number distally is 0.69. You can see there's step ups in between. And one of the nice things about software is that this curve didn't exist a few years ago when we first got this system installed. And folks like Bill, folks like me who use wire-based physiology said, wait a minute, we need to see the pullback curve because we need to make treatment decisions. It doesn't just matter what the number is. We need to understand where the drops in pressure occur. And because it's software, it can be iterated. And so that's essentially what was done. And what you can do is essentially turn these lesions on and off. And so what I've done in this particular case is the second lesion was basically turned off. And you see the white line goes to the green line. And that would be the effect of treating that proximal lesion. So I can ameliorate the pressure drop at that segment, but the distal FFR still is 0.77. So that's probably not going to be good enough. Now, what I do here is I actually just treat the distal lesion because maybe that's what's causing the problem. And I can actually get rid of that pressure drop. But because the proximal lesion is significant, the distal FFR still is under 0.8. And so ultimately, what you can do is you come up with a situation where if you treat those two lesions, but not the very, very proximal lesion, you end up with a distal FFR of 0.9 something. And so it tells me that I probably need to treat both lesions if I do want to alleviate the pressure loss within the artery itself. And the patient had a pretty compelling story, and that's what I did. I will tell you that my predilection prior to doing physiology in this way would have been to treat the proximal and leave the distal alone, because we know that distal lesions, if they restenosis, there are less options, et cetera, et cetera. But I don't think I would have ameliorated the pressure loss in the vessel had I done it that way. And so this was a real world case of how I use the technology to help me. I will also point out that at PCR just recently, we presented data from All Rise looking at the LAD and the performance of this in the LAD, because everybody wants to make sure that the LAD is a vessel that you can rely upon this. And we did show that just like in the overall trial, the results were very, very similar in the case of the LAD. And you actually didn't overtreat. The rates of PCI with wire or this technology were very, very similar. So let's go on to a more complicated case where we're not just relying upon the LAD, but we're relying upon what we see in real world clinical practice. Tough cases, tough patients, not just cherry pick type stuff. So this is a case where there's an osteo-LAD lesion and there's an intermediate lesion in the circumflex. I think you can appreciate it, especially in the LAO call or the spider view, that osteo-LAD looks real. And this is the age-old question of what do you want to do with this? Do you want to just nail the ostium? Can we nail the ostium? Should we cross over? But then what are we going to do with that circ? There's a lesion in the circumflexes there as well. You can appreciate just around the bed. And what are we going to do with it? So for me, this is a perfect case for physiology. I want to make sure that we're addressing the circ and not leaving behind a pretty ischemic territory. But at the same time, I want to be parsimonious in my strategy in terms of how to treat this. And so we start with this FFRangio because I've already taken the angiograms. This is essentially in our lab a free thing. We have a subscription model in our lab. So when it comes to this issue of cost, we basically pay a monthly thing. And so I can use it as much as I want. But what's nice about it is I can also get not only the LED, but the circumflex because it's all on the left side. So the LED is clearly 0.77, no questions there. It looked angiographically significant. But the circ is 0.92. And even though there was that lesion on the bend, there's not a lot of drop off in pressure. I always look at the pullback curve on the right, and you see there's not anything focal there or anything going on. So maybe the circ doesn't need to be treated. Now, here's just another example of the QCA distribution because you can change it from the pressure to the QCA. And you once again can see the lumen looks essentially similar throughout that whole segment. So what I did next is I actually did imaging. And I wanted to make sure that I understood the plaque characterization of the LED. I also wanted to look at the circ as well. And what you'll appreciate as this comes back is that the plaque does abut the left main. And in many cases, Gary Mintz taught me this, there's a circumflex coming in. It's very rare to have isolated osteolytic disease. It doesn't come back into the left main. On the right is the pullback from the circumflex, where you'll see there's a focal stenosis. There's some calcium there. Doesn't look overly obstructive. There's a lesion. Doesn't look overly obstructive. And now I'm coming back into the left main, and there's a LED wire, and so the ostium of the circ looks fine as well. So with that, I opted not to treat the circumflex. And there are some who say, well, I don't believe this. This is the technology. It's going to, overestimate, underestimate. Well, to prove to you that this number was real, I actually did RFR of the circumflex as well, and it was 0.94. So no questions there. It's not ischemic. So next step, you dilate the LED. And after dilating the LED, you see a reasonable result. But the problem is that as it often happens in these cases, you get axial plaque shift back into the left main because that plaque obviously involves that ostium and comes back to the left main as well. And so I did IVUS, and you can similarly, I won't belabor this, but on the IVUS pullback, you'll see that the plaque clearly comes back to the point where it's going to be very hard to nail that without leaving plaque behind. So once again, these physiology metrics are also complementary to the imaging. So we want to treat with imaging, we want to treat with physiology as well. And so basically the idea here was I was going to cross over. So crossover, stent, potted, recrossed, did kissing inflations, and this is what it looked like afterwards. And now the question comes, what do you do with the circ? Do you do physiology? Do you IVUS it? Do you just stent it? Do you DCB it? And so one of the nice things about this system is because the angiogram is already done and the setup is already there, I can just run physiology of this. And so I did IVUS, of course, and I'm not going to go through this in detail other than to show you the circ looked unchanged. The LED stent looked fine. There's the ostium of the circ. But yet the physiology was 0.94. And no change, no step up. It looks exactly identical to how it looked before I even treated it. So that gives me some reassurance. But for those that are still skeptical, I will prove it to you, and I'll do a wire as well. And this is the LED, by the way. I got a free shot of the LED showing that pressure loss had been resolved. Distally, it was 0.88. And so here's the RFR of the circ, 0.94. Was able to cross it, not too difficult. But again, it didn't involve a wire and manipulation, whereas with the technology of FFRangio, I could have just done it without wiring at all. And so ultimately, I left it like this. And one could argue, well, this is not complete revascularization. You didn't do a good job. But I think I did a physiologically good job. And that's ultimately what matters to the patient. So to me, why did I show these cases? I think, number one, to do angiography-based physiology intra-procedure, it offers you a wire-based way of doing this. And for this bifurcation, it's super helpful because you don't have to rewire or do anything else like that. It definitely can influence the treatment strategy. It does not need additional wiring and all of that. And rather than being competitive with imaging, it's complementary. And so gives you additional information beyond that provided by imaging alone. So maybe, Rasha, we can open it up for questions at this time. I think the point of this was to show that not only is there experiential knowledge with this, that there's also data now to back it up, which is really, really great. And I think now the future is kind of wide open for how this gets used in clinical practice.
That's great. Thank you very much, Ajay. So we've got loads more questions in the chat. So one of the questions that I'm going to pose to you is we're talking today a lot about the future, and someone has said, what about microvascular assessment? Is that coming? Where do you see that fitting with this software?
Look, I certainly hope so. I personally feel that CMD testing is obviously underutilized, but one of the reasons it's underutilized is that it's a pain to do. And there's also some risk associated with it. If somebody with a normal coronary, I mean, one or two guide dissections or things like that are devastating to the patient. And so I don't see any reason why this problem could not be solved using AI and something like that, looking at the angiogram or some other testing that's out there. It's being tested not just with this system, but with other systems as well. But I would predict in the next 5 years, 10 years or so, we should have some solution that makes it more streamlined than the current practice.
Okay, great. So you're getting all the hard questions. So the next question is, what about someone's asked about what about using FFRangio if in the case of just doing balloon angioplasty? I think they're mainly talking probably about DCBs. Um, does it work if there's a dissection, etc.?
Look, I think that the key thing is to recognize this is analysis of an angiogram. So anytime that you have these hazy abnormalities on the angiogram, even calcified nodules and things like that, you're gonna stretch the limits of these types of technologies. And so my feeling is that if you have a clear visualization in multiple views, yes, it probably should perform pretty well. It needs to be validated for sure. But these hazy dissection flap things that are dynamic and can change in a matter of 10, 15 minutes, then it's going to be challenged. So I do think it's usable. I think that Antonio, for instance, Colombo has been using physiology with wires post and to determine whether or not to stent and things like that. And maybe this could simplify that workflow, but just be a little bit cautious because sometimes the dynamic process and the resolution of the angiogram might not be good enough to determine what's going on.
Great. And I mean, I guess it's to the same point. Someone has said, what about if the arteries are very ectatic, there's slow flow? How might that affect the results?
So there are clear caveats. So, for instance, if you have diffuse disease where all the vessels look like they're 2.5, but they're 4.0, a QCA-based technology is not going to work as well, and so that's viewed as a relative contraindication. The same thing is true with massive ectasia. Usually two times the size or greater, or generalized slow flow and things like that. All rise, for instance, we didn't enroll patients with bypass grafts. We didn't enroll patients that had needed surgery potentially upcoming as well. Although I can say I've personally used it in multivessel disease cases many times. So you just have to use your brain and not try to get something to give you that which it can't give. So you use your brain, think about these things, and we've published on some of this stuff what's in there, what the inclusion exclusion criteria are, and if you familiarize yourself with that, you'll still be able to use it in a lot of patients.
Thank you, Ajay. I'd like to bring Bill in now and we can kind of open this conversation with both of you. So, Bill, someone has asked in terms of the setup and getting to the point of doing the angiogram, of doing the FFR angio, do you give nitrates? How do you get that angiogram to be as good as it could be?
Yeah, so that's a great question. Thanks. We looked at the need for nitroglycerin in the FAST FFR trial, and some operators routinely do it and others don't. Many of us, if we're doing a radial approach, will have nitroglycerin in the cocktail. So in essence, we're giving nitro before we do the angiogram. It turns out it doesn't really matter, that it works just as well either way. So it's up to your preference whether you like to give nitroglycerin beforehand or not, and you'll get a similar result either way.
Great. And what about, you talked a bit about this already, but opening up the angiogram, selecting the best views. I've noticed in my own lab, you have to get good at angiography again in order to really get the most out of this.
Yeah, and I don't find it's not like burdensome. It's just doing a good job.
Yeah.
I think sometimes we can get whether it's lazy or we're just trying to be quick or and we avoid just making sure that we're really imaging the vessel well. Now, this would be another limitation. I mean, if you have a patient with really severe kidney disease, not yet on dialysis, and you're going to do minimal shots, in that case, you may not be able to do FFR angio if you don't have enough shots. But you can do it with just 2 images. It doesn't have to be three, but the ideal scenario is three. And I don't know. I'll use whether I'm doing FFRangio or not. I'm going to be taking 3 images anyway of the vessel, so it's not a added burden in my practice.
Brilliant, Bill. So, Ajay, I've got one for you. I think it's right in your wheelhouse. Someone has said, can we talk about vessel discrepancies? And they've said, is it reliable in the right coronary artery and the circ as well? You spoke a bit already about the LAD subset. Maybe you could speak to that.
Yeah, so for sure, the best data for this is going to be from All Rise, which is a randomized trial. And in that setting, it looks like basically things perform as you'd see in the overall trial. But what's interesting, and I think people have made a little bit too much of this, is that in the LAD specifically, the rates of treatment or the rates of MACE were lowest among patients randomized to FFR angio compared with the wire. But the problem with those types of analyses are that what happens is that this is not a treatment. This is a diagnostic test. And so if you treat somewhat differently or you treat variably, then you may attribute the MACE rate to the to the diagnostic test when in fact it's just variance in the way the PCI was performed. And so what's really important is that in both groups, the LAD group and the non-LAD group, the rates of MACE among those lesions that were deferred are identical in both arms, whether it's treatment with whether it's with FFR angio or with the wire. When you treat, then the rates become a little bit discrepant, but I think there's noise in that based upon just the numbers, and it's not powered for that and that kind of thing. So my feeling on this is that if you use this technology and it gives you a number and you elect to defer, you're going to do fine no matter what you do. If you're going to treat, you have to treat really, really effectively and well, and sometimes that's going to introduce some noise into the results.
Yeah, that's
Rasha,
great.
yeah,
Yeah, Bill, go for
yeah,
it.
yeah, sorry to interrupt. I just wanted to jump in too. I agree completely with Ajay, what Ajay said, and it gets a little into the weeds, but I think it's important. When you first do a clinical outcomes trial, the investigators, they're new to this technique, and maybe their belief in it isn't fully, we don't have the data when you're doing the study. And what we saw in the right and the circ is that some of the quote unquote over treatment, was in patients who had negative FFR angios, and the operator kind of went against the protocol. Now, it wasn't a large number, but it was a couple percent here and there. And so that adds up. And that's why I think that contributed to some of the overtreatment. And my hunch is that now that we have these data, operators will feel more comfortable and, will be willing to follow the FFR angio exactly. Like, for example, in Ajay's nice case, a lot of people that circumflex, if they didn't have data knowing that FFR angio works, they might just go ahead and treat it even though it was negative. And so I think we may see less over treatment, quote unquote, in future studies.
Yeah, I like that. So there's some more questions around tips and tricks, and maybe Bill, while I've got you, ask some more. Someone has asked, do you ever use an automated contrast injection? Is it all right to do that if that's maybe your standard in your lab?
Yeah, it's another excellent question, and that has been looked at as well. And it's not required, certainly, but if that's your practice, yes, you can continue to do that. The key thing really is the angiogram and the images, and making sure you have good contrast opacification of the entire vessel for at least a few beats of the cardiac cycle, because the system will, it takes it during a certain portion of the cardiac cycle, and it's helpful to have the entire vessel pacified for a couple beats in order to optimize that. And so, yeah, if you want to use automated contrast injector, that's fine, or if you want to do manual, that's fine too. Just you want to fill the vessel.
Okay, perfect. Ajay, I'll bring you in again. Um, I know you've got it in all of your labs. Someone's asked, is it available for every angio machine? I think obviously this comes as its own system now provided by Medtronic, but maybe I'll turn that question to a question about the setup. So as you're trying to get this into your cath labs, what do you need and how do you kind of start the process?
I mean, you definitely need updated angiographic equipment. I think that it's all good and fine to say it works on everything, but I'm sure there are some labs around the world, particularly because your PCR has a very worldwide audience, and people are using some old machines, so it might not be fully compatible with all those machines. It does require a frame rate of over around 12 or so. So we tend to do cine acquisitions of 15. So that's okay. If you happen to do it at 7.5, you will have to adjust that. And then also it depends. I mean, so we have actually in our newer labs a system such that literally as you take every cine, it's immediately pushing to this console. And so you could do your shots of, if I'm a radialist, I typically shoot the right first. As you're doing your shots of the right and then move to the left, you can start analyzing the right while you're taking the shots of the left. I also, though, work in a somewhat older cath lab, Phillips room, similarly, where actually you have to push manually the images to the equipment, and so that adds some workflow limitations. So, what I would say is just get a sense and have somebody come over and look and see what can or can't be done, and then you'll determine what the best implementation will be. We also have versions where you can do it in the room, or you have it as a console and part of the control area. I kind of like the control area thing because you can sort of sit down and relax and that kind of thing without standing around the room.
Great. And so both of you spoke to, in your cases, the assessment of post PCI physiology. Maybe Bill, I'll ask you, where do you see this going next for that? Because that really is a place where we're not using physiology as much as we should at the moment.
Yeah, I think, of course, we need more data, and we're going to look at this in All Rise because we have post PCI angiograms, and we didn't do it as part of the study, but we're going to do it as a sub study. As we all know, measuring post PCI physiology with a wire can be very painful. Especially if you do your intervention over a workhorse wire and then you have to rewire through the stent with a pressure wire. I'm sure we've all struggled with that at times. So I think the advantage of streamlining will even be magnified in that setting. I, you know, I think post PCI physiology is helpful in that it's prognostically important. Meaning if you have a lower FFRangio value, likely you're going to have a worse outcome. The key question, and I still think we need data both with wire-based as well as angio-derived physiology, is can we modify or improve that outcome? We know that with intravascular imaging, if we have a suboptimal result, we can improve our outcomes by optimizing the stent. I think we still need to figure out the role of the physiology as far as guiding further intervention. It definitely is prognostically important, but I think there's still work to be done there.
Okay. Back to Ajay. We've been asked quite a lot about the correlation with intravascular imaging. Maybe someone's talking here about OCT, but I'd like to ask you about the sizing tool. How do you use that in your practice?
For me, I tend to favor it for length more than the diameter. We tend to use a lot of intravascular imaging in our lab, and I'm just more used to using that. There needs to be further validation of that, and probably because it's QCA based, it's going to have to be upsized relative to, for instance, a media to media measurement where people are downsizing based upon IVUS. So for PCI related things, it's useful. I think the length is actually very useful, especially because it can take into account the bends and stuff. But for diameter, a little bit suspect. And just the one thing back to Bill's point about lesion assessment, and you made the point too, Rasha, is that please don't use imaging for lesion assessment based upon MLA cutoffs or anything like that. Because remember, the vessels change in size, they taper. And so unless you're normalizing for that, you're going to be coming up with wrong measurements. And too often I just see people using like a 4 millimeter square cut point just to put in the stent. And I just don't think we should condone that type of practice.
Great. Bill, back to you. This is a really hard one. What about FFRangio in the structural space? Do you see any role in patients who are being considered for TAVI? Where do you think that's going to go?
Yeah, so that's a really interesting question. I definitely think there is a role, and you could argue that it may be more accurate than wire-based physiology. So, we know, say, let's take severe aortic stenosis, and you're evaluating a patient who's going to be undergoing TAVR, and they have a moderate LAD lesion. There are a lot of changes that occur with aortic stenosis, LVH. There's also hemodynamic changes, and both of these can impact wire-based physiology, whether it's FFR being overestimated because of microvascular or diastolic dysfunction that limit the hyperemia in the setting of aortic stenosis, as well as the valve kind of acting as a proximal lesion, so to speak. And then also non-hyperemic pressure ratios can be underestimated, meaning they're falsely positive because of some of the hemodynamic changes that occur. And studies have shown this when wire-based physiology has been assessed pre and post TAVR. Now, FFRangio should be immune to those things. And so your value that you measure before you do your TAVR should be similar to the one after. And so that may be very important and advantageous in helping to guide the decision. So, this is something we also need to investigate further, but I definitely think there will be a role for angio-derived physiology in that setting.
Great. Back to you, Ajay. I want to ask you about ACS. Someone said, is the assessment of FFRangio reliable? We know that we saw the data from All Rise. Only a minority of patients were in that ACS subset. What do you think?
Yeah, 10% in the trial. And that's why Bill is very passionate, as well as I am, about All Rise 2, which would be an ACS non-culprit scenario. I don't think you should use it for culprit assessment. Personally, I don't endorse using the wire for the culprit assessment either. I know there's some data on that as well, but I think you have to be a little bit careful about the fact that it's a dynamic process and there can be recurrent events at a higher frequency just by virtue of the plaque that's ruptured and angry and hot and all that. But for non-culprit assessment, there are data using angiography-based physiology. In the FIRE trial, Simone Biscaglia published this. They did use angiography-based system, a different system in that trial, not exclusively, but they did use it. And so I think this is ripe for the picking. I mean, while you're there, you're going to have the angiogram. We know that oftentimes these lesions over time maybe change a little bit, but overall, as long as there's nothing screaming tight, which is what complete shows the main benefit is for, perhaps we ought to be able to leave these alone. And wouldn't it be nice to have a physiologic assessment so the patient doesn't have to come back to the cath lab? So that's something that we're going to be actively investigating in the future.
Nice. Well, we look forward to that one. Bill, one more for you. So people often talk about this as a class of angio-based systems. They're all the same. We've got outcomes data now from two major systems. How does this roll out to the technologies that don't have outcomes data?
Yeah. So, I think if you think about, drug studies, if you have two medications that, work in an identical fashion with an identical pathway, you can often assume that, the outcomes will be similar. And with wire-based physiology, like non-hyperemic pressure ratios, where you're putting a same wire down and you're just measuring the hyperemic pressure ratio in a different part of diastole, but it's really a very similar method from beginning to end. I think you can assume similar outcomes. The question with angio-derived physiology is that there are some fairly significant differences, I think, in the algorithms and the way the system calculates the result and the operator interaction with the system. Some have more and some have less. Obviously, you want it to be user independent or as user independent as possible. And I think we have to take all of these into consideration. And yes, we have two studies now using two different systems, FAST-3 and All Rise, but we also have a third study that showed inferior outcomes with an angio-derived system. So that, to me, suggests that if the technique is different enough from one that's been proven, it's incumbent, upon us as, clinicians and clinician scientists to demonstrate that the outcomes will be similar to, an established mechanism of assessing physiology. So I know that's sort of, running around the issue a little bit, but I think, I don't think we can just assume that they're all the same.
Yeah, great. So keep those questions coming. We're trying to field lots of them to our experts. So yeah, please, I can see that there's a big Chinese audience who keep saying hello. Please ask us questions. That'd be great. Ajay, back to you. So we've got loads and loads of data coming from All Rise. What else can you tell us we're going to see? We're going to see cost effectiveness. Obviously, we've seen the LAD data set. What else are we going to expect to see from the data that we've already got?
We often do subgroup analyses and that kind of thing, which I think is important. What I personally think would be super interesting analysis would be we have the angiograms for everybody. And so we could look at the arm that was randomized to the wire and post-process and analyze what the angio-based physiology would be to try to understand exactly what the correlations are and where these things may differ a little bit. Because I think the thing that for everybody that you feel better about when All Rise comes out is that you want to know, can I trust this to make treatment decisions? And the big picture question is, yes, you can, based upon these data. But I think most interventionalists kind of would like to know, are there pitfalls? Are there certain areas where maybe the number is going to be slightly different? There's this whole issue of the hydrostatic forces, as we know that the LAD is a little bit lower and the circumflex in the right may be higher based on where you measure them. And so that can affect the fidelity of the wire. So some of these more nerdy type of topics are of interest to me because let's face it, I think we're all nerds in some way or another, and we want to know.
Yeah, if I
Thank you.
could, if I could jump in too, Rasha, and add
As
to
long
that.
as it's nerdy.
I also think, when you start using the system, you'll see that there's various approaches of meticulousness or nerdiness, if you want to use that term, to how many, for example, side branches get traced, and whether you modify the lumen measurements. I tried not to touch it at all and just let the system do its work. But I will have the ability to do that in the wire-based arm. We can reanalyze all of them and have someone not touch anything and just see what the number is versus measuring all the different branches, because I think that'll be helpful. Hopefully it'll show that you don't need to do anything, and then people will kind of relax, because I think we saw this in All Rise, and that was probably why I would have expected even more of a difference in the time to calculation being shorter with FFRangio. But I think some of our investigators are a little nerdy and really wanted to make sure that they were doing it perfectly, and that may not be needed.
Great. So you bring me to another point that I want to ask you, Bill. How many of, or what's the proportion of cases in which the angiogram won't be good enough and you just can't do this, or, the vessels are very tortuous or they're very overlapped or whatever. There are technical issues around being able to use this technology.
Yeah, it certainly occurs. And I think Ajay identified some of the scenarios. For example, if a patient's had a prior bypass where the graft is patent to the vessel, that we're not able at this current time to analyze those. Now, if they have like a bypass to the right coronary that's occluded and the right coronary is still patent and has a moderate lesion, yeah, you can use it even if there's like a lima to the LAD in the other vessel. That doesn't matter. You can still use it. So I think that's one area. Certainly, there are some patients where the vessels are just too overlapped. I'd say maybe that's 5 or at most 10% of cases. I think if you have a CTO and the vessel is supplying collaterals, extensive collaterals to that CTO, we still need to learn more about that and whether we can rely on it, because presumably the bed is a little bit larger. And so maybe the physiology would be, overestimated with FFRangio. So there are some cases, in my experience, it's less than 10%.
Okay. And we had a follow-on question from that. I think they were listening to you and thinking of other scenarios. What about myocardial bridges?
Mm. Yeah. Bridges are tough. I mean, they're
I mean,
tough.
they're tough all round, aren't they?
Yeah, they're tough with wire-based
Mm.
physiology. This is something we need to study. It's a great research project. Because bridges are dynamic and because the FFRangio uses, the end diastolic image, it may not appreciate the impact of the bridge. But then again, even with wire-based, it can be difficult and require specific assessment with dobutamine and things like that. So I think that's an area of further investigation.
Great. Um, Ajay, I want to ask you, in your hands, I mean, obviously, we talked a bit about how long this takes. In your flow, in your cath lab, presumably it's not you doing it, as you were saying before, it's the technicians outside who are helping you do it. How long does it take for someone to do, let's say, a 2, 3 vessel, more than one lesion, FFR
Yeah,
angio-based assessment?
I mean, the good news, we have some data from All Rise with respect to this, and it first of all was faster than the wire, so that's good. But then you're also not manipulating. But in my hands, I mean, typically it's going to be I plan like a 5 minute thing. But I will say,
Mhm.
although I'm not doing it myself, I'm
Yeah.
definitely like looking over the text or whoever's doing its eyes and saying, no, 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 you don't need to like recorrect that. You don't need to recorrect that because what I did when I first got it, because this is how I am with stuff in general, is I do it all myself and I like mess it up and I try to see if I mess it up, what it does. And then based on that, I realized pretty quickly that yes, you do have to trace the big D1, but you don't have to trace D3. It's not going to make any difference if it's small. And so all those little manipulations, when people go to the courses, they want to be really meticulous about it. You might not need to do that. And that's why I echo Bill's comments about I want to see this in All Rise validated. But for me, what it tends to be is as long as the images are there pretty quickly, the actual tracing part in general is going to be less than a minute. And provided the images are good. If you take bad angiography and everything's overlaps, okay, then it's going to take a lot longer. But that's why we're meticulous about our angiograms. And once we do it that way, it's pretty quick, under a minute, and then the thing runs over a period of time. So I would say 5 minutes or less is a general average for me.
Great. So, Bill, I'm going to give you one of the last questions, I guess, which will be, where do you see this? You have lived in the physiology world for so long, longer than many of us. You've been there in the kind of, rollout of wire-based technologies, now the angio-based technologies. We still don't see physiology uptake like we'd like to. Um, how do you think this is going to have an impact? And are we going to finally see people using it in the majority, particularly of their elective cases?
Yeah, we already are. I think I know of examples of operators who were not using physiology at all, who have now adopted FFR angio completely. And I think that speaks to the issues with wire-based physiology and the fiddle factor, and the concept that if you can make it simple, people will use it. And so what I see, I think people who were very heavily wire based may continue to use the wire or maybe use it more than others. But I think the overall usage of physiology is definitely going to go up because there are a lot of operators who know they should be doing it, but for whatever reason, aren't using it as much as it should be done. And now this will allow that to happen. So I anticipate that we'll see a significant increase in overall physiology utilization now that we have this capability.
Thank you, Bill. That's a perfect place to stop, I think. I wanted to thank you, Bill. Ajay, thank you so much for being here today. Thank you for educating all the listeners and watchers in the PCR arena who have obviously come to us from all over the world. Thank you to all of the audience for being with us today. Thank you for being interactive, sending us all your questions. And again, thank you to PCR for hosting this webinar. We'll see you again soon.